This talk is called The Transition to Value. Wait, no, not the transition to value. The transition to risk is the most important thing that's happening in healthcare today. Subtitle, Why the Free Market Will Not Make Healthcare Affordable. All right. So I don't think many people would dispute the American economy works. We keep getting richer and our standards of living keep getting higher. You compare our standard of living today to 1960 or 1940, we would be blown away by what even the poorest among us have access to. But what makes that work? What makes the GDP grow year after year? I mean, look, if you invested $100 in the stock market back in 1926, say nothing about access to the stock market, by the way. In just 5 years after 1926, your $100 investment would have been worth $20. You thought I was going to say a higher number, didn't you? But
I did.
It was the Great Depression. But if you held on to that investment worth $20, if you held on to it through the Great Depression, through World War II, your $100 investment would have grown to nearly $1,000. And if you held on to that through the 60s and 70s, in the savings and loan crisis of 1987, your investment would have been worth $10,000. And if you still held that today, that same investment you paid $100 for originally would be worth more than $70,000. And that's if you just kept it in stocks. Imagine if you bought Bitcoin with it. Okay. So humans can build big businesses, and it happens a lot in America. But why do humans build big businesses? We could all just be subsistence farmers. I live in northern Michigan. I know a lot of guys who would actually kind of prefer that. But why don't we do it? And if you ask an economist, they will tell you it's the profit motive. People are willing to take risks to try to improve their lives. Or if you look at especially immigrant families, they're willing to take risks and put their money and their time on the line to improve their kids' lives, not really their own much at all. All right. But the profit motive has kind of a negative connotation, especially if we're talking about healthcare. So I'm going to substitute a more positive phrase here. That phrase is mutual exchange of value. When we exchange value, something magical happens. That is, we both get more of what we want. I get more and you get more. So let me give you a concrete example. When you do a Google search, what are you hoping to get?
What I'm looking for.
Yeah, you want information. Yeah. And what does Google give you? It gives you information, and it gives it to you really quickly usually. Actually, I heard that there's a key metric in the Google search product, which is how fast the user leaves Google. So that one of their KPIs is using our service for as short a time as possible, because that suggests that we brought you value. We got you what you wanted faster.
Oh, nice.
Yeah. And because Google has your attention, because they have the information you're looking for, they can serve a secondary customer base, and that customer base is advertisers. Now, what do advertisers want, Syamala?
For people to buy their stuff.
Yeah, they want to sell their product or service. So they can buy from Google 1,000 clicks. Those 1,000 clicks might turn into 100 free trials. Those 100 free trials might turn into 10 paying customers. And as long as the profit from those 10 paying customers is higher than the cost of the 1,000 clicks, then the advertiser is happy. They put in money and they got back more money. Mutual exchange of value. Now, obviously, Google is massive, and not everything they do is amazing for society. But in general, people want answers more than they want to hide their intentions from advertisers. And advertisers are happy to pay Google money in exchange for more money coming back. So value is being mutually exchanged for the most part with Google. Let's take an even more straightforward example. Tesla. All right, when a person shops for a car, what do they want? It's an impossible question. Everybody wants something different. But imagine for a second that money is no object. Some of the things you might want would be a great driving experience, really fast performance, a car that's super safe, style. You want to look good while you're driving it, right? You want to feel like you're not ruining this beautiful planet we live on.
Right.
You might even want to feel like you're not sending manufacturing jobs to other countries. Now, luckily for a lot of people in this country, money is no object to them. And so when they buy a Tesla, they get to experience all of those amazing feelings that I just described. And when they buy a Tesla from Tesla, the company gets money, Elon gets money, and Elon and the company both invest that money into their real mission, which is renewable energy. Value is being mutually exchanged. People want the Tesla more than they want the money, and Elon and the company want the money more than they want to keep the car that they built. Because they can further the mission of sustainable energy. So let's think about healthcare now. It's exactly the same, right? Let's say you're so sick you need to go to the hospital. What do you want, Syamala, if you go to the hospital?
Feel better.
Yeah, you want to be well again, right?
Yeah.
And let's say the hospital cures you. You would rather be cured than have $5,000, right?
I guess when it came down to it, yeah.
Totally. So, right. Mutual exchange of value, right? It's perfect. I'm joking, obviously.
Yeah.
Okay. So going back to our previous examples, more successful Google searches, that means more people got the answers they were looking for. More Teslas on the road, that means more happy drivers and less fossil fuel burned. But both examples seemingly better for society, you would think. But if hospitals sell more hospital stays, does that mean that we are healthier?
No. Sorry, are you asking?
No.
Yeah.
No, it does not.
Not necessarily. Yeah.
No, it means the exact opposite.
Yeah.
More hospital stays means we are less healthy because we need to go to the hospital at all. So if we zoom out, a sicker population means more demand for healthcare, more healthcare services delivered, and more money for healthcare providers. A healthier population is exactly the opposite. Less demand, less service delivered, and less money. Nobody wants less money, right? So are we seeing a mutual exchange of value? Of course not. We're seeing a one-directional exchange of value. We're sending a bunch of money to healthcare insurance and healthcare providers. And what are we getting back for that? Oh, and by the way, I want to make it clear, our healthcare providers are not actively trying to make us sicker. At least the vast majority are not. I've met them. But they don't have an incentive to intervene early. They get paid for saving our lives once we're in the hospital.
Right.
Preventative care? Yeah, if you want to prevent profits.
Good one.
Thank you. All right. So what has this perverse incentive gotten us? All right. Since 1970, our healthcare expenses per person have gone from $2,000 to $11,000 per person. We used to spend, and it's not just in the absolute sense that it's gone up, it's also gone up as a proportion. So we used to spend 7% of GDP on healthcare. Basically, 7% of all our money went to healthcare. Now 18% of our money goes to healthcare. It's like on its way to tripling its share of our wallet. Doesn't seem healthy. And it's not just insurance payments that are going up. Out-of-pocket costs are up double in that time. Okay, so we're spending 5 times as many dollars, more than double the proportion of GDP. We're getting some good stuff, right?
Yeah.
Wrong. Since 1980, other rich countries added 8 years to their life expectancy. Our life expectancy started lower, and it remained lower. We only added 4 years in that time. So we literally spend the most money and get the least value for our money. I think we should get better at negotiating.
Yeah.
So it would be easy to conclude that the people who run healthcare delivery are profit-seeking monsters. But they're not. They're people with misaligned incentives. So let me give you a concrete example of misaligned incentives. Some people need percutaneous cardiovascular. Oh yeah, go ahead.
No, I was going to say something. Sorry.
Cool. Some people need percutaneous cardiovascular intervention. As a matter of fact, 15 years ago, this saved my dad's life. He would have died the next day, but he had a percutaneous cardiovascular intervention, and it saved him. If you're having a heart attack, it's way safer and more effective way to save your life in most cases than having open heart surgery. It's less expensive than open heart surgery too. It's an amazing medical innovation. You know what else people also need? They need therapy. Depression, anxiety, trauma, post-traumatic stress. these issues affect huge numbers of people. And if you have one of those mental health issues on top of a physical illness, all your health outcomes get worse. So if you go to therapy today, that could help you avoid a downward spiral that could put you in the hospital in a month or a year or maybe 10 years from now. But if you're a healthcare executive, you only have so much budget, right? You only have so much attention you can think about. So which one do you invest more in? The one that earns $1,500 a case or the one that earns negative $50 a case? Now, this is not
negative 51. Sorry.
No, this is not even a hard analysis. You're saving lives immediately and making a nice profit that you can invest back into more healthcare. Okay, so here's a less straightforward dilemma. That's a real dilemma. Hospital readmissions. So everybody knows that when a patient comes back to the hospital, that is evident of a breakdown in care. Something happened that shouldn't have happened. That patient shouldn't be back in the hospital. But readmissions are profitable.
Interesting.
Readmissions are profitable. So is there a financial incentive to reduce readmissions? There is because of penalties associated with readmissions. But in general, even after penalties, most readmissions are profitable.
Really? Oh, okay. Wow.
Yep. So I contend fee-for-service reimbursement creates impossible decisions for healthcare leaders.
Sorry, the meme.
Appreciate my meme game there?
Yeah, I do.
All right. So for those of you establishment healthcare folks, I hear you right now. You're saying, but Adam, we don't have true fee-for-service anymore. What about value-based care? Value-based care, you don't need to go all the way to risk. Value-based care is the answer. And that is exactly where we are right now. Almost every payment in healthcare is tied to quality in some way. But the incentives for quality are minuscule compared to the base payments that they're tied to. So imagine you run a factory and your factory sells widgets for $100 a piece. Now your best customer comes to you and they say, we would like to do a value-based contract. So for every crappy widget you send us, we're only going to pay you $90. For every adequate widget you send us, we're going to pay you the standard $100. And for every excellent widget you send us, we're going to pay $110. What would you do?
I don't know.
You would you would focus on improving your quality, but you would also focus just as hard on making sure you deliver as many widgets as the customer will buy. So again, easy analysis. In value-based reimbursement, you still want to sell a lot of services. You just want to sell services at the highest quality level you can. So I'm not saying that value-based care does nothing. It's just you can't make the incentive strong enough to outweigh the fact that the providers are still getting paid for volume.
Right.
So I contend it can't fix the value-based reimbursement, can't fix the cost of healthcare. It improves quality, but importantly for the status quo, it keeps the volumes nice and high. All right. It helps. It really does, but it's not enough. I've been in the room where it happens, and this is kind of the conversation doesn't look exactly like this, but
where what happens?
Sorry, that's a Hamilton reference, but like the room where the decisions are made.
Nice, yeah.
Yep. Okay. All right. So putting providers at risk for their patients gets the incentives aligned properly. So a risk-based contract would look maybe like this. You have 1,000 patients, and last year your 1,000 patients cost $1 million to take care of. So we're going to adjust for inflation. But at the same time, we expect you to improve the cost of care for your patients. So we'll take off 0.5%, and we'll say your budget for care next year is $1.025 million. Okay. Now let's say that next year, your patient's healthcare spend is exactly $1 million. Okay. So you've beaten the target and you pocketed $25,000. Basically, you get to keep the change is the way that a simplified risk-based contract would work. Okay, you came in under budget. You get to keep the change. Great. And so if you're a healthcare executive seeing this performance, you can start to say, just like Tesla, hey, if we can earn a bigger bonus next year, we can invest a little more in that community mental health partnership, or we could hire a data consultant to help us answer some questions about our patients. So what do you really do if you're a healthcare provider or delivery network on the hook for your patient's cost? You do an analysis and you start to figure out, have you ever heard of Pareto analysis?
No.
Or the 80-20 principle? Yeah.
No,
So there was this famous dude a long time ago who figured out that 80% of the peas in his garden came from the 20% of the pea pods that were most productive. And then he started seeing the 80-20 principle everywhere in his life. And so this is a thing that we do in healthcare is we say, what are the small subset of things that are contributing the most to this problem? So what subset of my patients have predictably high healthcare spend? Well, it's patients on expensive medications, people with cancer, people with chronic conditions like diabetes, high blood pressure. And then we look at those and we also start to look at what are the subsets of healthcare services that are most expensive. Well, hospital inpatient visits are pretty expensive, like 5 to 10 times as much as outpatient visits. And come to think of it, outpatient visits are kind of expensive too when you compare them to office visits. They're like 5 to 10 times as much as office visits. And so as we start to do this analysis, we can start to see an actual plan coming together. All right, so we're going to see what we can do to these patient populations, patients with expensive drugs, cancer, diabetes. We're going to see what we can do in the short term to lower the immediate spend. We're going to see whether we can move those services, the same services they're getting, to a lower tier of care. So if they were a hospital inpatient, but they were on the edge, maybe they could be a hospital outpatient the next time they come in. Are there outpatient services that we could be doing in the primary care office? Yes, there are. And then third, and this is the most important thing, we're going to see what we can do to identify the people who fit the profile of the already high utilizers, the people who someday will become the people with cancer or diabetes or using a lot of prescription drugs. And we're going to see if we can nudge them onto a healthier path. Now, if we were still paid in a fee-for-service world, there would be no financial incentive to intervene before people get sick because we don't get paid until they get sick. And so this idea of looking at so they call it the causes, Don Berwick calls it the causes of the causes. So that would be the things that cause disease. The hot term for this, which you are no doubt going to be researching quite a bit, is called social determinants of health. And it's exactly what it sounds like. What are the environmental or societal factors that make someone become healthy or unhealthy? All right. So when providers are at risk, everybody focuses on why the people need care in the first place instead of what to do after they get sick. And that is why risk is what's going to save us and not value or the free market.
Nice.
Cool. All right. So what's next? All right. As I mentioned before, the healthcare industry is not full of monsters. It's actually full of people who want to do the right thing, but have been poorly incentivized in the past. And people are signing risk-based contracts left and right. They're putting themselves at risk before they are required to, which I think is an amazing sign of goodwill and of good intention. Sometimes those people have a team of actuaries advising them that, yeah, we can still make money in this. And sometimes they sign the contract because it feels like the right thing to do. So personally, I'm going to try to help the people who are taking on risk because they're the heroes of this financial story. They're not frontline healthcare workers, but they are. They're making big decisions that I think are going to have a big impact on what the next 10 years look like for healthcare in this country. The degree of difficulty for those people who are signing those risk-based contracts, I think, is really high because they're negotiating. Opposite them at the negotiating table are insurance companies. Insurance companies do have a big team of actuaries who can do the math and make sure that the insurance company's butt is going to be covered in these deals. So providers have That's what I would call informational advantage. So providers can create their own informational advantage because the insurance company A doesn't have the data from insurance company B, but you're on the provider side, they could have the data from insurance company A, B, C, and D. So they could use that data to their own advantage. And so that's my mission, is to help them use their information, negotiate good deals for themselves, risk-based deals that let them lower the cost of care for everybody.
This is really like, it's all really good, right? Like risk-based like systems, like really good. Yes. But like, I guess my question is just like, how do we get people to move, like to actually like move towards this? Like, I feel like healthcare systems have kind of, like dug themselves in a hole that's really deep, and like, it's with insurance companies too. And like, there are just so many like moving pieces to it, but like, yeah.
Well,
How?
so
And
go ahead.
I was gonna say like, and like in order to get right like analysts and like people to like come and like be consultants and stuff like that costs like more money too, right? Mm-hmm. So like if people don't want to be spending more money and we're like, here's this new system, but you have to spend more money, like how do you balance that?
Sure. We don't want to be part of the problem. And so remind me to address that if I forget it. So the first part of your question was how do we get more people into risk-based agreements if they're not willing to do it voluntarily? And I see this is the federal government's role. So it would be totally reasonable for Congress to pass a bill tomorrow that says, sorry, providers, you're now at risk. Thanks and good luck. That would be a totally reasonable thing to do. What's happening absent that is that the Centers for Medicare and Medicaid Services are continuing to to create programs that put providers at risk in a way that providers are comfortable with, and so the more this has been an iterative process over about the last 10 years, and it started with ACOs, which you've been researching, and now they're coming out with new innovations that are taking the good ingredients of the ACO and the Medicare Shared Savings Program and combining them with things that are more in line with actual risk, and they're concocting them into new programs like Primary Care First and CMS Direct Contracting, which I'm super excited about. So as those programs start to become more successful and CMS can show that providers who take these programs don't go broke and that patient care either stays the same or gets better, then CMS can have the data and leverage to say, hey, I don't care if you like it. This is just the way you get paid. You've seen other providers that were successful in this model. So suck it up and deal with it. And so that's what I'm expecting to happen. And that's only our Medicare beneficiaries, which are not all the people who consume healthcare in this country. But my suspicion is that the private insurance companies have done the math, and they know that if they don't keep up with the evolving business model of care that Medicare is kind of leading the way on, if they don't keep up and stay, a step and a half behind Medicare, then they put themselves at greater risk for higher federal regulation.
Okay, so that's kind of okay. So
right.
The government can kind of like push insurance companies to follow suit. Right?
Exactly. Insurance is already a heavily regulated industry, and but they could always regulate it more.
Right. Okay, I was waiting for you to say that. Okay, cool. Yeah, and I guess my other question.
Yeah, the other question was, so your other question was, how do we make sure that we're not part of the problem? And this is something I'm very conscious of because in an indirect way, I am, you could count me, or you could count this company as part of healthcare spend in America. One of my favorite things to do, and one of the things that I think is most valuable, is automating manual labor that in 2020 shouldn't be manual labor. There are all kinds of machine to machine data transfer that's done by human hands. There's all kinds of report building and report generation that is done by human hands who just either are not trained in the same toolkit that we are. And people who are building reports, a lot of times, they're building a report to get information and then take action on that information. Well, what if they didn't have to spend any time building the report? What if they could just have the information like we were talking about with Google? And what if they could then start taking action immediately and improving care for more people? So that's how I justify it to myself at the very least.
You mentioned like social determinants and stuff, like how will, I'm kind of piggybacking off my presentation, like how will risk-based, like, how am I trying to say this? How will risk-based systems of care prioritize inequities and disparities between minorities and people of low socioeconomic status and people who don't have access to healthcare?
I mean, it's a great question. And so my guess is that, well, all right, so there are a bunch of health problems that are strongly associated with low socioeconomic status. And so as if providers are on the hook for patients outcomes, and they see, oh, these patients keep getting sick, and these patients also are of low socioeconomic status, and so we can start to see the factors that are contributing. And so then actually, so I've been in population health, meetings in the healthcare industry where they're talking about changing the foods that are available at the grocery store,
right,
to try to combat obesity and diabetes. And so one of the problems is that this has been nobody's problem, right? And so if you make it healthcare's problem, I think the people in healthcare are smart enough to find at least part of the solution. But if it's nobody's problem, it'll continue to be nobody's problem. That's it for this time. Thanks for tuning in, everybody. If you got value from this, please consider subscribing. Or if you're seeing this on LinkedIn, you can follow me to get every one of these in your feed. And if you work for a PO and you want to impress your boss, or maybe impress your board if you are the boss, then check out Find Your Leverage Point, which is a free step-by-step guide by me on how to put a dollar value on the overlapping incentive programs between your contracts. You can find that at analyticaliq.com. There's a link down below. Until next time, bye-bye for now.